Hello, and welcome to the Early Childhood Health Consultation February webinar, Fever, Breathing, and Pulse Ox, oh my, the vital signs that should scare you and the ones that shouldn't. My name is Maria Morgan, and I'm the project manager here at Early Childhood Health Consultation. Our team is so excited to have you join the conversation today. Our program is in partnership with the Wisconsin Department of Children and Families, housed at the University of Wisconsin School of Human Ecology, and funded by the Preschool Development Grant. The Early Childhood Health Consultation's mission is to support Wisconsin early childhood education providers, or ECE providers, in addressing health-related questions and concerns, offering guidance on best health and safety practices. Our program envisions a sustainable and statewide model working through health consultation to improve quality ECE programs, best health and safety practices, and centrally promoting the health and well-being of children across Wisconsin. The Early Childhood Health Consultation Program acknowledges the American Indian tribal nations across Wisconsin and commits to working together in partnership to understand the health and safety needs and tailor support to best meet those needs of each tribal community. For today's conversation and webinar discussion, we will begin with a few introductions, have central content, offer time for live Q&A, and also have some reflective closing. A few features we'd like to highlight within the Zoom webinar. First is the chat feature. Right down at the bottom of your panel, you can select the chat icon. And then from there, you can drop down and select to send your message either to just the host and panelists or to everyone. We'd also like to highlight the Q&A feature. If you have any questions throughout today's webinar, feel free to utilize the Q&A. Once you type your question, you can send that or send it anonymously by selecting that check mark as you see here on the screen. For today's webinar, we will be talking through describing the role of vital signs when making health-related decisions in early childhood care and education settings, identifying which vital signs need immediate healthcare attention for children, and finally, identifying early childhood health consultation as a resource for Wisconsin ECE providers on health and safety questions. So for today's discussion, we will have the conversation conducted by our very own Early Childhood Health Consultation Director, Dr. Dipesh Navsaria.
Great. Thank you so much, Maria. I really appreciate it. And thank you to everyone joining today. It's really a delight to have you here and to be able to spend some time talking through vital signs with you. I'm going to go ahead and get my slides appropriately shared here and make sure I have the sound on because we will have one video as part of this. And then I'm just going to quickly just reorient my screen here because everything always seems to end up in odd places. All right. Should be good at this point. Okay. So again, thank you so much for being here. And I want to highlight that even though the title says vital signs, I'm not expecting that we're actually going to be spending time, asking you to measure vital signs in some, way, shape, or form. What we are going to be, but I'm using it as a way to think about when you're looking at a child and you're trying to put some sort of objective lens on it and say, okay, is this an issue? Is this something that adds to my concern or maybe helps me feel better about what I'm seeing? That thinking about these in different ways, I think, will be very useful in a whole host of different ways. So that's really the goal of what we're looking to do in our time together today. Okay, so first of all, let's start off with some definitions. What is actually a vital sign, and why do we call them vital? Because there's all sorts of things that we could be looking at, and there's ones that are carefully picked out. So let's start with that definition, and this is probably the longest sentence I'll put on the screen here, right? They're a group of different medical signs of things that we find on examination that tell us how the body's doing in terms of the things that are necessary to sustain life. Okay, that's why they're vital. And you might think, okay, that's pretty obvious. But when I sometimes pose this question to our medical trainees, it's like, well, why do we call them vital? What's going on with those? Is sometimes something we need to have a discussion on. And the reason we look at them, at least in medicine, is because they help us assess just overall how's someone doing. It may or may not be useful about a specific thing, but it may tell us generally how they're doing. Might give us some clues about what's going on, and also just help us understand like what their progress to recovery is like. Are they able to go home now, or is the medication working? Vital signs can be a part of that, but they're certainly not the only thing. Okay, so what are the things that we consider vital signs in general? So I'm again trying to be a little interactive here for you. Let me ask you to put in the chat at this point. What are things that you think of as vital signs? What are the types of things that we might measure or assess in any setting? I see blood pressure, breathing, pulse, temperature. Yep, pulse, heartbeat. Yep. Yeah, so I think people have covered. So yeah, oxygen. Yeah, we'll come to that in a moment. Yeah, okay. Yeah, great. Not so much eye movement, interestingly enough. It can be important, of course. Yeah. Okay, great. Yeah, I think you nailed all the ones that are typically considered vital signs. So there's temperature, right, assessed through a thermometer. There's what we call heart rate or pulse. Pulse is technically the thing you're feeling, whereas the heart rate is the thing that we're measuring. I see someone said severe cough. We'll come to that. That in and of itself is not a vital sign, but it is something we need to think about. Then there's also respiratory rate, or how fast they're breathing. Okay, it's not all it tells us is a number, right? That's what a respiratory rate is. And then, of course, blood pressure, which we measure with a blood pressure cuff and so on. Is there a fifth or sixth vital sign? Yes, there are. So there was this movement, long time ago. I mean, maybe 20 years ago, to say, well, pain should be a vital sign, right? In the sense that we should be asking about it and prominently displaying it in different places, because we need to be able to assess that and think about it, right? Is it truly a vital sign by the definition I just gave you? Most would argue perhaps not. It's not to say it isn't important. It's just how we think about it. And then I have to say, like, it's almost a joke in medical circles about everything being the newest vital sign, because there's what some of you mentioned, right? The oxygen saturation, or pulse ox, and we'll come to that. Is that a vital sign? It wasn't when I started training, because almost no one had a pulse ox, because those were actually pretty expensive and you only used them in hospital settings. And now it seems like everyone and their brother has one around, which may or may not actually be useful. And then people have argued that things like chronic hunger should be a vital sign, or housing, so like everything's a vital sign. And of course, if everything became a vital sign, it would be too much. So anyway, little sidebar there, just to kind of give you a sense of some of the conversations that we have, that, everyone thinks everything should be important, right? But if everything's important, then it's hard to catch up with that. So let's break down the four key ones, right, that are traditional, because again, these are the sorts of things that mostly, not exclusively, but mostly you can look at in your own early childhood settings, and help that guide like your judgment about how ill is this child or not. So let's start off with temperature, right? Because I think this is the one that most people think of, and it's the one that we probably measure the most frequently in particularly in non-healthcare settings like homes, or in your early childhood centers, or whatnot. So first, let's talk a little bit about the devices themselves. So the old school thermometer that, was a little glass tube, and it had what was first a little bit of column of mercury in it, and then later changed to kind of an alcohol solution. That's the red ones. Those have largely gone by the wayside, not because they had problems with how they well, they worked. They actually were really good and really accurate. The problem is, one, they're glass, so if they break, that's an issue. And number two, there's the alcohol is not such a big deal; it's a tiny amount, but the mercury is toxic, right? So no need to have that around, especially where kids might mess with it or break it, and then now there's mercury exposure. So they moved over to digital thermometers that pretty much serve the same function, yeah, except as a little digital display. And they're so inexpensive now that, they're a few bucks. It's accessible to pretty much everyone. So that's what you see mostly being used, is those sorts of thermometers. What you might also see or even have are all sorts of different ones. So there's also the ear thermometers that you kind of point in at the eardrum, and it uses infrared to get a temperature measurement that way. There's temporal ones that use kind of scan the forehead or the sides here of the temple. There's a nice artery here. You can actually feel your own pulse there usually, that it's using to kind of work off of that. That's reasonably accurate, and that's fine. What isn't fine are the LCD strips that change color that you just kind of hold against the forehead. Those seem to be rather inaccurate, and I just don't see them getting used that much. So if you still have one or see them, please don't use those. Or the pacifier thermometers, right? That they think, oh, well, just put it in a young child's mouth, right? It doesn't get it where it should be, which is under the tongue when you're doing it orally. So also doesn't seem to be all that accurate. So again, all you need is an inexpensive digital thermometer. You do not need some of these really fancy ones. Do you need these that are connect to your phone and have Bluetooth and Wi-Fi and hey, you want to go ahead. But that seems like a lot of record, a lot of features and all for not really changing a whole lot about the most important thing, which is the number. Now, I want to make a key point about measurement here, and those of you who've been to our webinars before or watched the recordings this has already come up, and I'll just repeat it again. Measurement is use the number that actually appears on the device. Do not add a degree, do not subtract a degree, do not do anything else to it. The number is the number, irrespective of where you measure it. So in an infant, we're often looking at something like a rectal temperature. That tends to be highly accurate. You can position it well, etc. Although sometimes we'll even do armpit temperatures in infants, and that's often okay to get a sense of what's going on. Oral is great when the child is old enough that you can get the thermometer reliably under the tongue. That can be hard in an older child, and when their mouth's closed, you can't tell, is their tongue up or down or whatever. So that's why we use these armpit temperatures so much. They're just not all that invasive. They're relatively easy to do. If you're wondering why the armpit, one, it's an area that stays pretty warm and pretty close to what the core temperature is. There's also a big artery that comes off the heart, like almost directly to that space on either side. So it's a good approximation of what the core body temperature is, and not, something else. But again, do not add or subtract a degree. I've told this story before, and I'll say it again. I had a child who was once brought in. They were told that their child had a fever, but no other symptoms, nothing at all. No cough, no runny nose, acting fine, all that stuff. And I discovered that they were adding a degree, which brought it just above the temperature that would be considered a fever. And I was like, yeah, no, this child is not ill. Please just go home. So even though that myth is still out there, please do not do that, because it just creates illness or creates a change in how we might look at things where it isn't warranted. I also want to add this notion of, so what's a normal body temperature? So the study, the textbook answer is 98.6 Fahrenheit. The study that established that is about 150 years old. You can imagine that their ability to actually measure was probably not as good as ours is now. And it also didn't take into account that, hey, our body temperatures change over time. Any of you that have ever done temperature tracking, like if you were trying to predict when you're ovulating or not. We know that the temperature taken at the same time every day can actually vary based on things that have nothing to do with illness, right? So body temperature does vary, and skin temperature can vary. So sometimes even feeling their forehead, there's some kids who it's pretty obvious they have a fever just by feeling, but it can actually be off. And it might not actually tell you what's really going on. I still remember when I was in training, I was actually going to afternoon lab where they were demonstrating biofeedback, and the biofeedback device was a little temperature probe that they just taped to your finger, and then they would use the temperature to help monitor some things about your state. And I was just learning about this, so they were demonstrating on me. And when they put the probe on, they said, "Oh, your temperature's on the high side already. That can't be right." And I said, "Oh, I just biked here from across town. So of course I'm going to be warm." And they're like, "Oh, okay, right." You can imagine the kid who's just been outside running around on the playground may also have a warm skin temperature as a result, and maybe even their whole body temperature might be somewhat elevated. So what's normal? Generally speaking, in medicine, we say 100.4 or higher is considered a fever. Am I going to quibble over 100.2 or 100.3? No, I'm not. That's close enough. It's the ability of the thermometer to measure that precisely is gets called into question. But I hear a lot of people, including parents and others, saying, "Oh, he has a 99.4. That's a low-grade fever." Okay, so here's my next thing. You notice how I have a line through the words low-grade fever. I don't use that phrase ever. There's no such thing as a low-grade fever unless you're talking about 100.4, 100.5, 100.6. Fine, it's a fever. But this sort of thing in the 99 world, that should be considered normal. Do not consider it to be any indication of a fever. It's simply part of that variation. If we were to do something slightly silly like measure temperature in perfectly healthy looking kids every day, which we could, if you want, for kind of an informal study, you'd find that their temperatures do vary and go all over the place. A great question in the chat. And again, I want to highlight, feel free to put questions in the chat if there's something that relates to what I'm just saying now. If there's something that you think is bigger that you'd like me to address at the end, put it in the Q&A box and we'll make sure that we get to it there. So the question is, do you find the reliability of digital thermometers has decreased over time, or if they're dropped? I don't know that I would say that they're worse off, that they're less reliable than say 10 years or 15 years ago. I think they are tested and they are supposed to be reasonably accurate. So there is some quality control that's going on there. I would say that honestly, the reliability issue sometimes is like positioning in the mouth, positioning, in the arm. I mean, got to be careful that when you position in the armpit, like the probe is not sticking out the back of the armpit in the air, or things like that. If they're being dropped frequently, that can affect any electronic device. So I think if it's a question, it's probably not a bad idea to replace it. But yeah, in general, I don't think that the digital thermometers in and of themselves are better or worse than they have been. And again, I'll just highlight, please don't ever add or subtract a degree. Some people have added a degree in some settings, they've subtracted a degree if they take it rectally. Just, if you're trying to convey what it is, just say what the number is, because that fact that a degree was added or dropped sometimes gets missed in how we're told what's going on, and that can potentially affect how we might view the situation. So, okay, here's the thing though. What does fever really tell us? Okay, because you didn't come here to kind of get an academic treatise on, the finer points of how the 98.6 standard was arrived at, right? That the question really is, what is this really telling us when it comes down to it? For the most part, fever tells us that the body is responding to an infection. It tells us nothing about What kind of infection? Is it bacterial? Is it viral? Rarely fungal, or parasitic. We have no way of telling that from the fever. Yeah, there's a few exceptions, but for the most part, right, it does not tell us that in and of itself. There are situations where a child could have a fever that are not related to infection. Those are extraordinarily rare. Okay. Just some kind of rheumatic conditions, some autoimmune conditions, et cetera, et cetera. That's rarer. And if that's a likely possibility, somebody should be telling you that, hey, this child may run higher temperatures. It's not related to an infection, so that you're not taken by surprise, on that. So what does a fever really tell us? It just tells us there's an infection. And the number on the thermometer doesn't tell us a whole lot either, beyond is there a fever or not. Young children, like for a 2-year-old to have 104 temperature is not unusual. We see it all the time, and it may be from something that's just, a self-limited viral infection that will go away on its own. It's more unusual for me to see 104 in a 12-year-old, right? That seems less common, and that might raise an eyebrow on my part because we just don't see it. But again, the number itself doesn't tell us much about the severity of what's going on. It just simply says there's something here. So we should also be careful to not put too much stock in fever as a measure of like overall health or overall severity of illness, because it just doesn't really tell us that. The other thing is this concern that I hear from so many folks about fevers being dangerous, right? That, oh, I had to keep it down, and sometimes I'm asking, it's like, so tell me why you're trying so hard to keep it down. And sometimes there is this question of this idea that, well, if I don't keep it down, something bad's going to happen. And sometimes it's this idea that the fever in and of itself is dangerous. So is a fever actually dangerous? And the answer is generally not. Oh, okay, yeah, sure. If you're sitting at 104 for, hours upon hours upon hours on end, right? You're going to sweat more. You're going to, lose some water, right? Could you get, at higher risk of dehydration? Sure, you could, but that takes a long while to get there. And, I wouldn't go there, worry about that on the basis of like a fever being there for a short period of time. Now, the two things people worry about often is like, well, this fever is this fever is going to cause brain damage. Fevers themselves do not cause brain damage. Let me tell you how people got to that conclusion or got to that worry that's there. There are many things that cause fever and that might cause something bad like brain damage, like meningitis. Okay, meningitis is an infection of the lining around the brain and spinal cord. That's a bad thing, right? You don't want that to happen. And if there is meningitis, it can cause brain damage. It can also cause a fever, but the fever didn't cause the brain damage. It's the meningitis itself. So treating the fever and keeping it down isn't going to fix the meningitis. If it's bacterial meningitis, you need antibiotics for that, right? That's a very uncommon condition, by the way, in kids these days. And that's partly because of, yay, immunizations. We do not see meningitis anywhere near the rates we used to. It's actually been profound. The pneumococcal vaccine, the Hib vaccine, have dropped bacterial meningitis rates in young children to extraordinarily low rates. Yay, thank you, vaccines. This is the sort of thing I have to worry less about when I see a kid with a fever, because of advances in immunizations. So the brain damage thing is not an issue. I will say, can there be issues if the temperature goes extraordinarily high? Yes, those are usually temperatures that are only achieved when you have a child who's been, for example, forgotten in a locked car on a hot summer's day, right? When the external heat is so high that they're getting up into the 108, 109, whatever, right? I've not seen a fever from an infection that gets up to 107, for example, and even 106. I think I've seen once, and that was unusual. Usually it's 104 or below. So again, fevers themselves do not cause brain damage, and I think it's important to note that. What about seizures? Okay, this is the other question that people have. Febrile seizures are a really interesting thing. So what we in medicine call simple febrile seizures, and that's just a phrase we use to identify like some characteristics of them. I want to be clear, they are frightening when they happen to the people around and all. Simple febrile seizures are a kid who does not have a seizure disorder, right? So they do not have known epilepsy or a seizure disorder, whatever term is being used. Who, and it's usually young children, right? Under age 3, we're often looking at the toddler age group, and not necessarily infants, but so two-ish or so. And they're ill from something, could be a standard viral illness, and their temperature goes up, and they have a seizure that lasts less than 15 minutes, and it's generalized throughout the whole body, okay? So not just an arm twitching, not just a leg, but the whole body. Those things altogether are what we call a simple febrile seizure. It's generalized, it's less than 15 minutes, and they don't have a known seizure disorder, and they are otherwise in good health at all. Those are so, they have no consequence in terms of the child's health. They do not cause brain damage. They are not an indication that they have a true seizure disorder. They're just something that happens. And they're probably related to some sort of genetic predisposition that we haven't been able to identify yet. Okay. They are scary to the people around them. Totally get that, right? But if everything else sounds good, and if the seizure's over, they'll be sleepy for a while. This is normal after a seizure. And then if they wake up, they're usually doing fine. They don't even necessarily need to be seen by us. Don't get me wrong. I'm sure many people would bring their child in and want them looked at and all, and that's okay if they're that concerned. Happy to see them, right? But there's not usually any other evaluation that needs to be done. And by the way, I'll tell you, I say this as a parent of one of my 2 children had febrile seizures. My daughter had them twice as a toddler. The first time I remember, she was home ill. She had a viral something. And was running some fevers. And I remember we were home and my wife and I were talking, and we heard a sound from upstairs. It sounded like the cat throwing up, except both cats were on the first floor near us. So we're like, eh. Went up there and looked, and she was in her crib and was seizing. And I was like, yikes. Now I remember when the sound started, and so I hit my stopwatch. It lasted about 4 minutes, right? Because when I ask parents this question, how long do you think this lasted? They're often like, I don't know, it seemed like forever, because it does feel like forever, doesn't it? Anyway, it stopped after 4 minutes. We called her pediatrician, and they were predictably, yes, they were like, well, okay, sounds like everything's okay. You do not need to come in, unless you want to, but we're not hearing anything that's a concern. And she did fine. Her second febrile seizure, amusingly, was in her childcare center, in her teacher's lap. They were reading a story or something, and she wasn't even ill. She just suddenly seized, and when somebody measured her temperature, she did actually have a fever. So it was actually right at the beginning of her illness. It was the first sign. That didn't happen again, but they understandably they panicked and they called an ambulance. So we ended up going to the ER and all, but she was fine. It was simple. It was viral. She never had one again after that. She's 19 now, so she's long since outgrown them. So seizures are scary. There is a couple of myths out there that I just want to add. People say, oh, the seizures happen when the temperature gets too high. Nope. My daughter's temperature when they measured in the ED was 101. Okay. And I very much doubt it was too high earlier. Then they said, oh, maybe it's the speed of the temperature going up. Nope. Turns out it's not that either. The seizure can happen at a pretty low fever, and all. And we strongly advise, even if children do have febrile seizures, that people should not be like giving them Tylenol every day to try to prevent it or something like that. That's not good for their livers and other things. And it doesn't seem to actually prevent it reasonably. So great question in the chat. When would you, and I realize not everyone can see the chat depending on who people are sending it to, but the question is, when would you call an ambulance for a seizure? If it's prolonged, right? If it's less, I would say, if it's getting above, 10 minutes for sure. Or if it seems complex, right? That it's not just the whole body, it's just one part, or anything else that seems concerning. And let them come and do an assessment, right? I'm not trying to turn you into a mobile emergency room. I'm just giving you some guidance there. But those would be things that would be more concerning and in need of an evaluation. Again, parents should, of course, be told that their child had a febrile seizure. They should be told that relatively quickly because they may be choosing to come and get their child and take them for evaluation immediately, and so on. But the question of when would you call 911 and get an ambulance there, certainly, if it's getting above, a few minutes, or if there's anything else that might be concerning. If you're not sure, I think it's okay to call that ambulance. I hope you have very few seizures that you deal with in your lives. And I would not expect you to kind of be making that judgment, the same kind of judgment I would make if I'm in a clinic and I have someone seizing and we're unable to break it and they need more sorts of things. But the biggest point is fever alone in most kids is not going to cause brain damage. It's not going to cause seizures. So let's just keep that in mind. Okay, let's move on to looking at heart rate for a little bit. I put this table here just to give us something to notice. These numbers can change depending on which book or reference source you're looking at. This is literally off of Wikipedia, which actually uses some very good references for this, which you can look up. But you will, if you look at different sources, these numbers will be a little bit different. So if you have different numbers in your head or look up different numbers, it's just because there's no accepted kind of normal. But you notice how high the heart rate is in newborns, right? I mean, to be up there ticking away at 140 or so, yeah, see it all the time. That's a normal heart rate. As they get older, that starts to drop somewhat until finally, when you're a teen, you're kind of more in the adult range there. So, again, heart rate does change over time, and I think it's important to note there. I do see a question that comes back to fever that I want to make sure I address here. Is fever considered contagious to others in a child care center? So let's remember, fever is a symptom. It is not the infection itself. So fever itself is not contagious. The thing that causes a fever, like the virus, may be going in different places. So I'll come back to the next question on policy because we'll try to cover that at the end. Do remind me in case I forget here. So heart rate does drop over time. Heart rate is actually very easy to measure, but I'll tell you, I almost never have anyone telling me what their child's heart rate is. It happens every so often, but I don't get parents coming in. I don't hear that report. And again, you measure with a pulse check either at the wrist that many of us are used to. You can measure it behind the arm here in young kids, so the brachial pulse there. You can measure it up here, the carotid pulse, or you could even just measure, directly here and just look at a watch for, 30 seconds and multiply by 2, and that tells you how many beats per minute it is. I'm not saying that you need to take a pulse. It's just there's a lot of measurement of temperature, but not necessarily so much heart rate. But just in case you do, here's what that number tells you. And then there's respiratory rate, which again, there's a big range. Little kids breathe much faster, and that is normal. Okay, so 40, which would be like kind of concerning in an adult, is totally normal in a newborn. And as you can see, it slows down to adult rates also as you hit the teenage years and so on. Here's the thing, though, and also I almost never hear a respiratory rate being reported to me from parents or early childhood centers, even though you can also measure that just by looking and with a watch, with a second hand there. Here's the thing, though, that number on its own might help me somewhat, but it doesn't tell me much more than that, because when you just give a number, it's not telling me what is happening. What is that heart rate really like? That breathing really like? and how much work is this child having to do? This is also true of the pulse ox, the oxygen saturation. Pulse oxes have gotten really common, and I think especially with COVID, people were really just going on about how people should have home pulse oxes and all that. And I found that a little puzzling, to be honest, because we have all sorts of complicated mechanisms in our body that if the oxygen saturation is dropping to a significant level, like something that actually matters, we should be working harder to breathe, right? That we should feel that, and we should be able to notice that in other people. So relying on a pulse ox seemed a little odd for most situations. There's always some exception out there, right? But for most situations, it seemed a little odd. I will also tell you that pulse oxes are challenging to get in younger children. They move a lot. The little probe with the tape on it that we often use, because the big clip thing doesn't work as well in children. The little probe sometimes doesn't stick well. And I find we're often spending an awful lot of time trying to get a pulse ox, and it's not even clear that's telling us a reliable answer sometimes. I had a child that was roomed in clinic just the other day, where the person rooming said, sorry, this kid is kind of all over the place, but their pulse is 217. And I'm just looking and I'm like, okay, I think you just read that off of the pulse ox. 217 is an insane pulse. I mean, it's actually, the heart can't go that fast without having something wrong with it. It's just too high a number. So I basically ignored it. And when I listened to his heart, I could tell it was nowhere near that. And so on. I've also seen reports of pulse oxes that are just like shockingly low. And I'm like, this kid's running around the room. There's no way it's that low, right? So no, I don't believe the number itself. There's also sometimes this desire with oxygen saturations with pulse oxes that it should be 99% or 100%. It often drops. If we see this in the hospital all the time, patients who are sleeping, their saturations do drop a little, and that's normal. Happens all the time. Happens at home. We just don't sit there with a pulse ox with someone recording it. And often, like, somebody will tell me, "Oh, this kid's pulse ox is 92%." I'm like, "Yes, and what are they doing? How hard are they working to breathe?" A child who's at 98%, who's sitting there working really hard to breathe, I'm more worried about than a kid who's sitting at 94% and is fine, right? Like running around the room or whatever, right? We have to take these things in context. So just measuring a respiratory rate, and this is why I'm like, I don't actually think it's important that you measure a respiratory rate, but I do think it's important that you look and say, hey, how hard is this child working to breathe? And sometimes that can be subtle. I'm going to give you a story from my own life. When my son was about 3, I went to pick him up at the end of the day from his early childhood center. Wonderful folks, nice center, great longevity in the staff. They had someone who had been there for 30 years straight, somebody else who'd been there for 20 years, really well respected in the community, all that stuff. Walked in, said hi to the teachers, and he's going around the room, he's playing, all the parents are showing up. It's the usual kind of end of day chaos there. And I kind of looked at him from across the room. He was wearing this loose sweatshirt, and like, I said, hey, come over here, Came over and I pulled his shirt forward, and I could see he was doing a little, what we call tracheal tugging. So if you look at the top of the breastbone, where that little notch is, you could see it sucking in and out just a little bit, and I looked at his ribs and I could see them appearing and disappearing a little bit. Not terrible, but I'm like, okay, he's actually in mild respiratory distress. It's really mild, and he was acting normally, right? No one noticed. No one had noticed. And I don't know when it started, because who knows, but it had been going on for presumably a little while. So whatever, he was playing. I was good. I was okay with that, right? But it was like, okay, he used to call me for, every loose stool he had, and he's having mild respiratory distress. And I saw that, we took him into his doctor's office, and that was his first diagnosis of asthma. And he got a neb treatment and all. So he's outgrown his asthma since he's 20 now. He does triathlons. He's all good, right? So all is fine. I see a question about the recording. Yes, recording will be available and it'll be on our website. All of our webinars are recorded because we've realized not everyone can make it. But I also appreciate your words that this is helpful. It's nice to see the affirmation. So I want to show you a video of what respiratory distress can look like. This is off of YouTube. Okay, it's a physician who took this recording. He says at the end he got the mother's permission to be able to take this and to share it so that others can learn from it. There's some really strangely cheesy music that is so weirdly not appropriate for this, but whatever. So just take it with that. But the video is really helpful at the different types of things you might see. Now, this is a little infant, and clearly this infant's not doing well because you'll see they're in the hospital, et cetera, et cetera. But I think it'll highlight the sorts of things that we look for. And again, you may never see because they are relatively rare, but if you see it, it should make you say, hey, wait a second, this is something that I should, be a little concerned about because this kid's working harder to breathe than they typically should. Because somebody said something about coughing earlier. Coughing doesn't tell me a lot. It tells me something's going on, right? But coughing is just a cleaning mechanism for the lungs. It is not, repeat, not a disease in and of itself. It's a sign of something. But what I really need to do is to actually look and say, is this kid working hard to breathe? That's more worrisome to me than coughing. So let's watch this video here. And I apologize, he throws some technical terms in, don't worry about them.
So you're getting about 90 breaths, and so now he has a VSD and an ASD and a little pulmonary stenosis, I guess. But he's been sick and coughing. No fever, though, you said, right? But he's been coughing and
coughing like that for the last
and he had a period of apnea. Is that right? He just stopped breathing
yes.
on Monday,
Yes.
and someone had to blow in his face.
Yes.
Is that right?
He got choked. He get choked off of that whatever he's coughing.
Okay. But he's only had like what, 2 ounces today, you said?
That's all.
Yeah.
When he started coughing, he turned blue.
Okay, as I said, strange choice of music. I'm sure he's an excellent ER physician. I would not hire him to do video production. Yeah, we'll share the we'll share the website. It is on YouTube, so it's publicly available. And I so appreciate that a parent was willing to let him take this video and have that conversation so that other people can learn from this. This was a child that has a known heart defect and some other issues. So, but that meant that we could see really clearly the trouble that was going on there, right? The belly kind of breathing, coming in and out with every single breath, the ribs appearing and disappearing, the little suck in at different places, right? So those are examples of those are the things that worry me. And in fact, I can usually tell when I walk into a clinic room within the first 5 seconds what's going on. Actually, I'll tell you, I was in urgent care last night and I walked in and I'm looking at this child and it's like, oh, that child looks like they're working to breathe. Not emergency, not, oh my goodness, get me oxygen. This is, call the ambulance to take them to the emergency room. But it's like, okay, we got to sort this out. I did end up sending them to the ER in different ways. There's a great question about, they mentioned abdominal breathing. Is there a right way to breathe lung breathing? I think the distinction we're trying to make is that most people, the breathing is up here in the chest, right? It's right. And if you see their belly kind of coming in and out, mind you, if they've just been on the playground and are out of breath, of course they're going to be in mild, doing extra respiratory work. That's normal. We expect kids to do that. I'm talking about the kid who's been there, sitting there, and they just also look ill, right? They look uncomfortable. That sort of extra work of breathing is the sort of thing that we should be looking at. I do see a question about what do you do when there's an asthma attack? If this is a child who is known to have asthma, like they have that diagnosis, you should have ideally received medication from the family with instructions about what to do. That was decided on by their regular doctor. If they don't have a known case of asthma and you're like, wow, this child's wheezing, they're working hard to breathe, that's not something you're going to have the ability to immediately do anything with beyond get them to more help. If it's severe enough, that would be an ambulance or 911 call. Or if it's not super severe, but you're like, hey, this child's working a bit, they're breathing, hey, call the family and say, your child, this looks a lot like when I've seen asthma. Is there anything that, we don't know yet, or what would you like to do, and get their guidance at that point. Generally you're not in an emergency room. You're not going to have the ability to treat that. All right, blood pressure. This slide is pretty straightforward because honestly, you shouldn't need to measure this in like pretty much any circumstance. If you're really worried about the blood pressure, you're probably got the ambulance on the way. They'll take care of it. There's all sorts of nuances about even telling you what the normals are is a complicated thing. It drives us a little bit bonkers in healthcare. Because it's not as straightforward as it is in adults, and you need to know how to measure it. Some of you may know how to take a blood pressure, or you might have automated cuffs. But again, if you're going to that level, something's deeply wrong. This would not be a reasonable expectation on anyone's part. So, all right. So I want to get to my last thing here before we go to some questions and all is a quick thought experiment. I do this with a lot of our trainees, and this is it's not really a trick question, but it's something that it's a nice way to think about all these things with vitals. If I gave you the highly artificial scenario that you were allowed only one vital sign to assess a child, what would you choose? So let me ask you that. If I told you you're only allowed to check one of these things we've talked about today, temperature, heart rate, respiratory rate, or blood pressure, which is the one that you think is the most useful? Seeing heart rate, seeing breathing, seeing temperature, breathing. Yep. I see no one's going for blood pressure since I carefully already told you that I wasn't even going to talk about it. Yeah. Okay. Yeah. Yeah. So the answer in my brain, and certainly people can debate this, but the answer that I tend to go with in a child, oh, sorry, here's the four that forgot I had those all out there. My answer generally is, yep, it's the respirations, it's the breathing. You might notice we spent more time on that. Most of my time on temperature was spent kind of helping you think about the myths and all that are out there. But yeah, respiratory rate is what I generally go with, and not just the respiratory rate, but what does this child look like? What is their breathing like, and all that. Also, if a child is going to end up with something life-threatening, I am also going to tell you that that's usually respiratory in nature, right? It could be a foreign object, right? Something that they got into their breathing passageway and might be blocking or partially blocking the area. It could be a pneumonia or something else that's causing issues, or asthma or whatever. Adults are much more likely to have, things not working right, like a stroke or other things that are out there, or heart attack or things like that. and maybe pulse or something like that might be useful, but breathing's probably the thing, and not just the number, but the quality of the breathing. And yeah, it's fairly easy if you're just wanting that number, right, to just simply count out, go for 60 seconds and count. 60 seconds is a long time. You could also do 30 and just double it, and that's usually close enough. But yeah, respirations. I had a slide here about the brief story. That was the story I already told you. I forgot that I had a slide on this earlier about my son and noticing that his work of breathing there. So really, the thing that I really want to emphasize is it's not just about vital signs. We shouldn't be going with this number means this, and therefore, that's it. But the question should be, how does this child look, right? I'm looking at them and you're looking at them and saying, this child just doesn't look right, right? How are they acting, right? The pulse ox, sometimes, I remember once in clinic, they had it was a 4-month-old baby, and it was taking forever to room them. And I'm like, gosh, what's taking so long? And I finally just walked in there and they were, oh, we're so sorry. We're having a hard time getting the pulse ox. This child was in mom's arms, sucking down a bottle, like easily without stopping. I'm like, you know what? I don't need the pulse ox. They're doing just fine feeding. You have to hold your breath a lot to be able to feed. So if you can do that, you're doing fine, right? So I didn't need a number to be able to tell me when I'm just looking at the kid and saying, I think we're fine here. Thank you. You can leave. Let me get on with seeing them. So how are they acting? How are they looking? All those sorts of things. And what are their needs, right? Are they needing to be held or not? All these things that don't come into vital signs, right? That we can't really measure in the same way, I think are really important to think about in so many different ways. So thank you for all that you do. Thank you for coming and listening today. And at this point, I'm happy to take your questions either in the Q&A, or I also have eyes on the chat here. And I am going to scroll back up just to address a couple of things that people asked about. There's a question about recommended temperature to have a policy to send kiddos home, or should we just be reevaluating? And then also, what is the temperature of a child who needs to be isolated or sent home? Again, temperature doesn't tell us enough. So there's nothing about a fever in and of itself that should make you say, no, they need to get sent home immediately or not. The question it should ask is, why does this child have a temperature, right? What is the thing that is causing this temperature? And that's where we come up with that question. Again, if you look at the Caring for Our Children guidelines that I've mentioned on this webinar before, and we'll keep on mentioning, they offer some good ways to think about all of these. And I think it's important to look at those, because it'll help you see what are good general inclusion and exclusion criteria. I will also tell you we're working with our valued partners at the Department of Children and Families to develop a model policy that you can start with and use as a guide to be able to build out policies if you're looking to rewrite your policies, that offers some better guidance. But there's not a magic number that we would do on that, because it could be minimal or it could be all sorts of things. All right, just scrolling through here. Thank you for all the thank yous. It's wonderful, particularly on a webinar where I can't see anyone. It's just great to know you're listening and appreciating that's out there. I see another question that came through in the Q&A. Can I send a child home because they don't look well? I feel like if I said that to a parent, they would not be happy. Yeah, that's a tough one, isn't it? Right? So I think what I would encourage all of you to do here is to have some faith in your own abilities to look at children. You spend a lot of time around a lot of children and say, something doesn't seem right here. That, like, I say this to families a lot. I say, look, you know your child best. You spend more time with them than anyone. I only get to spend a short amount of time with them in the clinic, but I have the benefit of having looked at thousands of kids at this point in my career. Right? So let's put your knowledge about your individual child together with my knowledge of having seen many and put that together. You folks actually sit right in between. You get to spend a lot of hours with some of these children, and you also get to be around a lot of other kids. So your gestalt, your feel that this child is not acting quite right. I think it's fair to call a parent and say, your child is just not looking well, and try to put some language on that, right? He's usually happy and playful, but today he just doesn't seem there, or whatever the case may be, right? He's usually got such a great appetite and he just seems lackluster today. I'm concerned something's going on, and it's not something that I can put a finger on what it is, but I wanted to check with you, see what your observations were, and maybe, do some, you might want to call their healthcare practitioner and just see, or see how he does tonight, right? Honestly, I got to tell you, most parents, sometimes they come in and they say to me, yeah, they just felt he wasn't looking right today. There was no fever, nothing. Okay, that's information. Like, how this child is behaving is important. When I write my notes, it's actually sometimes in the general examination, like, how does this kid overall look? I'll often say things like, seems tired appearing in mom's arms the entire visit, versus child actively exploring room, quarreling with siblings, etc., right? Just to say, okay, this kid looks really good. I'm not too concerned about them. I think you should trust that intuition, because it does mean something. And I think that's the beginning of a conversation, not just well, that's it, they should go home. So, all right. Thank you for the wonderful questions. Thank you for all your participation in the chat today. And remember, we're here for you. I will turn it back over to Maria to close us out and give you a few final bits of information. Thank you very much.
Great. Thank you, everyone, for your engagement in our conversation today. We would just like to recap that the Early Childhood Health Consultation Program is here to help support your best health and safety questions and needs within the early childhood care and education settings. And how we do that is we offer monthly webinar trainings just like this one here, as well as our on-demand resource library that can be found on our website. We also offer tailored health consultation to eligible locations. Please feel free to reference our website to find out if your location is also included in those service areas. Here on the screen and in a moment in the chat, you can reference our contact information, including phone call or text, email. You can follow us on social media, and we also have our website. We would like to say a special thanks to the many early childhood care and education providers who offer us ongoing guidance and best meeting their needs, including our very own advisory board of early childhood care and education providers. We'd like to thank our colleagues from other childcare health consultation programs across the United States, our current project partners, as well as our past project team members. A few logistical reminders following today's webinar. You can expect a Qualtrics survey being dropped in a moment into the chat. This survey is an opportunity for you to offer us feedback on our webinars as we shape future webinars. And it also offers a space for you to enter your information if you are interested in continuing education credit for the Wisconsin Registry. Also, following the event, we'll be sending a follow-up email to all registered attendees that include the webinar recording, as well as a copy of that survey link, just in case you need it. And then also a couple of weeks after today's event, we will enter any information that was submitted through the post-webinar survey with the registry for your attendance records. And we will make this webinar recording available on our website and our YouTube channel. We'd also like to take a moment to invite you to join us next month and save the date on March 2nd. You can access more information on the next webinar and future webinars directly on our website. So now I'm just going to go ahead and mention that the survey can be found in the chat for your ease of reference. And I'd like to say thank you again. It has been a pleasure having the dialogue and discussion. Dr. Navsaria, any final remarks?
No, just to say thank you all for the amazing work that you all do for children and families throughout the state. And we hope you're finding all of the work that we do helpful and useful. Please write in with questions, observations, and tell your friends about our webinars and other offerings.
Great. Thank you all.